Excellent. So a warm welcome to all the 165 participants, out of whom some of them are seniors and teachers and established teachers in the field of psychiatry who can obviously contribute their knowledge to this complex topic that we are discussing. And a warm welcome to all the young, enthusiastic postgraduate residents who have taken the time out on a Sunday morning and to spend time to understand this complex disorder. Very aptly, when Dr. Nurul approached me for a topic for postgraduate students, he suggested, sir, there are a lot of topics which have been dealt with, but this is one particular topic wherein people have trouble in conceptualizing as to where it stands in psychiatry nosology. Is it a schizophrenia spectrum disorder? Is it a bipolar affective disorder spectrum disorder? Or is it something unique of its own? How do we understand it better? And can we actually kind of have a session on it so that we can deconstruct the conceptual understanding of schizoaffective disorder? And I was happy to accept the invitation by my good friend. And therefore, let us spend the coming 40 minutes in trying to understand schizoaffective disorder. And in between, I will encourage the postgraduate students who have logged into this particular meeting to contribute whenever there are questions open to the floor through the chat box. And I'm sure the organizers have something special planned for the first resident or the postgraduate student who manages to answer some of the questions during the course of a class. So good afternoon. And as is the case with any particular conceptual understanding of a topic, we need to first understand the history and evolution of this complex schizoaffective disorder. It is not a particularly new disorder because Carl Baum, way back in the early 19th century, and had described about the Vesania typica circularis, and he had spoken about how there is a kind of a circular pattern to this particular insanity, which is affected, which is also having a huge burden of affective symptoms as well. Then came the Zendig's review of Kreplinian dichotomy, wherein he said, okay, Kreplin seemed to kind of come up with this manic depressive insanity and dementia precox, but there is a unique 30% profile of patients which Zendig saw, which he felt were not fitting into these two categories at all. And so he said that, okay, this is something that needs to be investigated. And subsequently, Kreplin himself came up with a response to that and said, yes, I do agree with this, that there are something called as a Zwischenfälle, which means to say that there are the cases in between which don't fit into a typical course of a schizophrenia disorder, that is dementia precox, or a manic depressive insanity. The father and son duo, who are famous in the field of psychiatry, that is Eugene Bleuler and Manfred Bleuler, also called it by a different name called as mixed psychosis, whereas their student, that is Jules Angst, said that, I don't think that this is psychosis per se. And he actually pointed out to the fact that this particular mixed psychosis that my teachers have actually described seems to be more of an affective illness and not the psychosis spectrum illness. So since then, to date, we have not resolved this conundrum, but hopefully by the end of the class, we would have some answers to this complex disorder. So before we proceed, can somebody tell me whose particular study in the field of schizoaffective disorder came as a case series, which then kind of snowballed into a lot of research in the area of schizoaffective disorder? Do type in your answers in the chat box. And as I think Dr. Siddhan has already kind of answered, it is definitely the Kassanin's report, which was a famous 9-patient report on schizoaffective disorder, which made persons to actually kind of examine whether this is a unique nosological entity in itself. So, but there was a rebuttal, like everything in psychiatry, there is always a rebuttal. And Weiland in 1963, when he re-examined, he did what is called as a post-mortem of all the 9 patients. When I say post-mortem, I meant the post-mortem of the case histories and not an actual post-mortem. So when he did an examination, a thorough examination of all the 9 cases that Kassanin had described, he actually said that almost every schizophrenia patient could actually be diagnosed as having a schizoaffective disorder. And so he was really questioning whether we should have a unique trajectory for this particular disorder and a unique classificatory status for this particular disorder. Then came the era of nosological evolution. In DSM 1 and 2, schizophrenia subsumed schizoaffective disorder. So it was a type of schizophrenia. It's only in DSM 3, which heralded a lot of changes in the area of psychiatry, especially with respect to the era of operationalization and the criteria-based categorical classification of mental illnesses, wherein they said, all right, this seems to be slightly more unique. So let's not put it as schizophrenia because they seem to have a better prognosis as compared to other disorders. Let's call it a psychotic disorder, not otherwise classified. And when the revision of the DSM-3 happened, they came up with more and more specific criteria for this schizoaffective disorder spectrum, wherein they said it is the psychotic symptoms must be present for at least 2 weeks beyond the resolution of a mood symptoms for us to really say this is something unique and this is not a part of the schizophrenia disorder itself. In DSM-4, it resembled DSM-5, except that it slightly harmonized with the ICD definition and concurrence was given more prominence. And now with that particular background, let's look at what is the current understanding of schizoaffective disorder in ICD and DSM. But before that, I will spend maybe 2 to 3 minutes explaining what is the current conceptualization of schizophrenia, revising the current conceptualization of schizophrenia, because this is so much important for us to actually understand schizoaffective disorder. So we all know that DSM-5 has made it easier for us to diagnose schizophrenia, wherein they have said that there are core symptoms. There are 3 top core symptoms which must be present for a period of at least 1 month, which is very prominent, and it should kind of go on for a period wherein it lasts longer than 6 months. And out of these 5 particular symptom domains, they have given a special emphasis to delusions, hallucinations, and a disorganized speech. So mind you that these 3 are very integral or given special prominence in the DSM-5 conceptualization of schizophrenia. So it's now easier, isn't it? If you find a person with delusions or hallucinations and negative symptoms, you can who satisfy the 6 months duration criteria for at least 1 month period during which it was very prominent, then you can go ahead and diagnose a schizophrenia according to DSM-5. But what is also essential is the other things that are explained in DSM-5, which we often omit, wherein DSM-5 says that the entire duration of illness, that is including the prodrome, the period of active psychosis, and the residual symptoms, must be continuous for at least 6 months duration or more, which is why they have a separate category if it is lesser than 6 months duration, which, as you all know, is classified as a separate disorder. Now, they have also specified for schizophrenia that schizoaffective disorder and a psychotic mood disorder must not be the diagnosis. And they have specified, of course, like any other illness, that it should not be due to the manifestation of a general medical condition, or it should not have any other organic etiology to it. Whereas ICD-10 conceptualization of schizophrenia focused very much predominantly on the first rank symptoms. If you were to kind of paraphrase and sort of make notes of the ICD-10 criteria for schizophrenia, you would understand that there is the A criteria which talks about the thought phenomenon. There is the B criteria which talks about the passivity experiences. There is the C criteria which talks about the running commentary, voices discussing or voices that is emanating from the body. And there is the D criteria which really talks about bizarre delusions. And it talks about E to H criteria, which we are well versed with, and I criteria, which is unique in that it can in itself satisfy the criteria for a specific subtype of a schizophrenia disorder that was called earlier as a simple schizophrenia disorder when it was present for about a year or more. Now, when we came to the conceptualization of the time duration of schizophrenia in ICD-10, of course, the difference between DSM-5 and ICD-10 is the fact that in ICD-10, you needed just about a month or more for the diagnosis of a schizophrenia disorder, and it excluded prodrome from its conceptualization of a disorder. Therefore, the prodrome could have been for several months together. They needed the active symptom phase for about a month or more for us to actually really diagnose schizophrenia disorder, with A to D criteria receiving a very special emphasis. Now coming to the ICD-11 conceptualization of schizophrenia, wherein they have also harmonized their definition somewhat with the operationalization of the DSM-5 criteria for schizophrenia, wherein they have spoken about at least 2 of the A to D criteria being present, and out of these, at least 2 of the all criteria present, out of which 1 criteria must definitely be from persistent delusion, persistent hallucination, disorganized thinking, and experiences of influence, passivity, or control. So one of the core symptoms must be from these 4, and plus they could have an additional symptom from criteria E, F, and G, which spoke about the negative symptoms, the grossly disorganized behavior, and the psychomotor disturbances. Now, when it came to ICD-10 schizoaffective disorder, they had actually specified that both definite schizophrenic and definite affective symptoms being prominent simultaneously within a few days of each other and in the same episode of illness. So if you look at it, there is a lot of focus, there is a lot of emphasis on the concurrent manifestation of the mood symptoms and the psychotic symptoms in ICD-10. That has always been the case, right? So please keep this particular concept at the back of your mind. And they have also specified that schizoaffective disorder cannot be applied when the schizophrenic symptoms and the affective symptoms occur in different periods of the illness. For example, ICD-10 had a category called as post-schizophrenic depression. So obviously, because a whole lot of 30 to 50% of the patients undergo this post-schizophrenic depression, you couldn't really make everybody as schizoaffective. So this is because this is a unique category in itself. Therefore, they made it a point that concurrency is something that they gave a lot of value in ICD-10. So the episodes had to be recurrent, and over a period of time, longitudinally, they had to actually find out that they were actually interspersed on top of each other. Mind you, ICD-10 also had a room for life course perspective of the schizoaffective disorder, wherein they said, over a long period of time, if you find 1 or 2 episodes wherein psychotic and mood symptoms are superimposed and overall otherwise it resembles a bipolar disorder, ICD-10 really gave us the freedom to go ahead and still diagnose it as a case of bipolar affective disorder and not as a schizoaffective disorder. So in that sense, although the operationalization of the definition was concurrent, the life course perspective was also filtered in while we are actually diagnosing schizoaffective disorders. So coming to the important point, right? So when we read in between the lines and when we read each line in the ICD-11 with respect to the schizoaffective disorder, there are a lot of clues that we get as to where schizoaffective disorder actually stands. Number 1, it is classified under a primary psychotic disorder. Mind you that the words that were used to describe the psychosis in ICD-10 and 11 are different. Can any postgraduate student who is logged in tell me what was the earlier heading for the primary psychotic disorders in ICD-10? Anybody? What was primary psychotic disorders chapter heading called as in ICD-10?
Sir, schizophrenia, schizotypal and delusional disorders.
Absolutely, absolutely. I think that's correct. And thank you for actually talking about it. Now, if you look at it, so conceptually, there has been a paradigm shift in the naming of the chapter itself, wherein currently it is classified as a primary psychotic disorder. No, it is classified as a primary psychotic disorder because ICD-11 has gone one step ahead and told that psychosis is the defining feature of the group of disorders that we are going to talk about in this chapter. So therefore, we have got a big clue from ICD-11 as to where exactly we will place schizoaffective disorder. Earlier also it was in the same chapter, but very kind of, like all things in psychiatry, they had taken a very neutral stance and given it as a code of F25 in between F20 and F30. So people were really unsure whether it really kind of had a place of its own. But now they have clearly specified that these are primary psychotic disorders because psychosis is their defining feature. So that's one major clue that we have got. The second important clue that we get from reading ICD-11 schizoaffective disorder is that they say that for schizoaffective disorder, patient should have psychosis, plus either they can have concurrent manic episodes, concurrent mixed episodes of whatever severity, but very, very importantly, the severity of the depression must be moderate to severe in nature. Now, this is not spelled out very clearly. You have to read in between the lines to understand this conceptual basis for why they did this, because they thought, when through the field studies, that mild depression can be a part of the psychosis syndrome itself, as a part of the psychosis schizophrenia disorder itself. A person who's undergoing severe psychosis would obviously be scared, would obviously be having a lot of mild depressive symptoms. So even if it is syndromal, if it doesn't satisfy the criteria for a moderate or a severe episode, ICD-11 says, hold on, don't call it schizoaffective disorder as yet. However, ICD-11 was categorically clear that that's not the case with a manic episode or a mixed episode that is concurrently following on each psychotic episode. Next important point that ICD-11 gives us the clue regarding is the fact that despite the episode definition, they have also told that there should be a continuous specifier of a schizoaffective disorder, wherein if for about a year or more, wherein all definition requirements are met, so you can still call it as a schizoaffective disorder. Now, this is a unique situation wherein, although ICD-11 gives emphasis on concurrency, it also gives a specifier called as a continuous course, wherein all the criteria that we have listed for a schizoaffective disorder is fulfilled, and it says that you can still diagnose it as a schizoaffective disorder. And in schizodepression, when we're talking about schizodepression, so ICD-11 actually says that of the 3 core criteria of depression, which are, can anybody tell me what are the 3 core criteria of depression? Type in the chat box, 3 core criteria of depression.
Pervasive low mood, lack of energy, and lack of interest.
Excellent. So the 3 core symptoms of depression, which always takes precedence over the other symptoms, are pervasive low mood, anhedonia, and anergia, isn't it? But mind you, in case of schizophrenia, you can have anhedonia, you can have asociality, which can appear as anergia, and apathy, which can appear as anergia. So they have recognized this conundrum, and conceptually, if you read in between the lines, ICD-11 has clearly specified that if you are diagnosing schizoaffective disorder with the depression polarity, please keep in mind that depressed mood is an essential criteria. Right. Next, coming to further reading in between the lines. So in schizoaffective disorder, they have also given us a huge advantage of getting the life course perspective, wherein they have told that there is often a history. I think there might be some disturbance. I request participants if they can mute themselves. Yeah, thank you. So in ICD-11, they have actually kind of spoken about a life course perspective, wherein they say that there can be prior history of mood episodes. There can be prior history of a depressive disorder, of a recurrent depressive disorder, of a bipolar disorder, even in patients with schizoaffective disorder. Now, this is a major advantage that ICD-11 gives us, which means to say that ICD-11 has accepted the fact that not all schizoaffective disorders breed true from the first episode itself. So there can be the first few years of the illness, if you were to call it as stage 1 and stage 2 of schizoaffective disorder, wherein the course can resemble a mood disorder, right? And ICD-11 also says there can be a prodromal phase in schizoaffective disorder as well, right? Very important point. Please keep this in mind. Distress and dysfunction are essential features of only one particular disorder in the psychosis spectrum, wherein it talks about the schizophrenia. Whereas for schizoaffective disorder, ICD-11 and DSM-5 say that distress and dysfunction need not be an absolute requirement. So these are things that you will understand by rereading the definitions and the conceptualizations of schizoaffective disorder. And of course, ICD-11 has also spoken about how schizomania is more common in the young, whereas schizodepression is more common in the older adults, and schizodepression is more common in females, just like how we understand depressive disorder being more common in females. See, the only component that changed in ICD-11 from ICD-10, if you actually read it entirely, is the fact that the definition of schizophrenia changed, but overall the concurrency was still the different and the definition of specifiers were different. So by now, through the first quarter of my presentation, I hope that the students have been able to understand conceptually what are our understanding of schizophrenia in ICD-10, ICD-11 and DSM-5. What is our understanding of schizoaffective?
Doctor, doctor, we lost your voice, doctor. Kindly unmute.
Am I audible now?
Yes, doctor, you're audible.
Yeah. So sorry, there was some echo that was happening. I hope that now that everybody is muted, let's hope that this doesn't happen. And moving on, the other important ICD-11 remarks that we need to kind of understand is the fact that the diagnosis of schizophrenia and schizoaffective disorder are only intended to apply for the current or the most recent episode of the disorder. Mind you, this is also very important, wherein they say that over a period of time, they have learned to accept the fallacy of these distinguishing these two disorders in watertight compartments. So now they have also kind of, agreed to this particular life course perspective, wherein schizophrenia and schizoaffective disorder will be playing an up and down role, wherein sometimes a patient might have schizophrenia and at different times the patient might have schizoaffective disorder. So to overcome this conundrum as to what do we do overall, they have asked us to take the life course perspective, number one, and also more importantly in ICD-11, they have asked us to focus on the recent episode, because management wise, this recent episode is what will have a lot of value, isn't it? So it doesn't matter if the patient had schizoaffective disorders 10 years ago, and then since then doesn't have any schizoaffective episodes in the outbursts or outbreaks of psychosis for the past 5 years, and we say that still it is schizoaffective, so let's actually go and treat with a mood stabilizer. So understanding this particular concept, ICD-11 has said, let's look at the most recent episode of the disorder and try to apply the diagnosis based on that and the life course perspective. So therefore, they have given a lot of provision for the interlude between schizoaffective disorder and schizophrenia. Next very important point, you have to read in between lines to understand this. This is important because it says that at least 1 month of syndromal mood symptoms must be there. Mind you, can any of the PGs tell me what is the duration required for a syndromal depression and a syndromal mania respectively according to the ICD?
Syndromal depression 2 weeks and mania 1 week.
Excellent, isn't it? Now here, however, they have said 2 weeks and 1 week will not do. That is not enough in itself, because we are giving a huge fillip. We are calling it as a schizoaffective disorder. 2 weeks, 1 week is not enough anymore. They have actually said syndromal mood disorder. And you also you also please remember, I spoke about moderate to severe episode of a depression or a mania episode or a mixed affective episode, but that has to be present for a greater period of 1 month or more. Why 1 month? Because according to ICD, schizophrenia can be diagnosed if schizophrenia symptoms are there for 1 month or more. Therefore, 2 weeks or 1 week is in itself not sufficient to diagnose a schizoaffective disorder. So I hope that we have classified some of these important things. So next, I will ask a particular question. So what if a person doesn't satisfy the duration criteria for affective syndromal mood disorder more than a month, but he has had a schizophrenia, let's say a schizophrenia illness of about 1 month duration, and then afterwards 2-3 months of remission, and then afterwards the patient has developed a syndromal mood episode, and what are you going to call it? What is the diagnosis in such cases?
Schizophrenia.
Schizophrenia. Okay, somebody says schizoaffective.
Depression.
Still,
Right.
it is schizoaffective only, sir.
Still it is schizoaffective disorder. So a lot of dilemmas are there, isn't it?
Sequential type.
Right. So it is important to understand that because of the polythetic and the multiple diagnosis provisions that ICD-11 and ICD allows us nowadays, as compared to the old Fuel's hierarchy, which was making us forced to choose a particular diagnosis, which is former in the classificatory system. If the duration is less than about a month, or the severity is that of a mild depression, then perhaps we can call it as a schiz with a mood disorder at this point of time and wait till they cross over for about a month and diagnose it as a schizoaffective disorder. If, however, it is non-syndromal in nature, then it is very clear that we are dealing with a predominant schizophrenia illness, and the schizophrenia illness, it is subsumed, will have some mood symptoms that are associated with it, especially if they are of the depressive polarity. So the first important concept that I want to kind of drive home is, after the first quarter of my presentation, is that a schizoaffective disorder is a nosological nuisance, but a clinical reality, which we need to kind of understand conceptually so that we can help our patients. Now moving on to a review of some of the categorical models of schizoaffective disorder and understanding its course and outcome and how it can help our patients. All right. So if we actually kind of have some, let's have some fun while we are trying to understand this schizoaffective disorder. This is an example that is used in NIMHANS most often than not. So if you understand schizophrenia or schizophrenias as a variety, and let's say that as an analogy, we will say horses represent schizophrenia, whereas say donkeys represent bipolar affective disorder. Mind you, this is just to drive home a conceptual understanding. I am not comparing persons who are suffering from mental illness to animals, but this is just a conceptual understanding. All right. So if you compare the conceptualization of schizophrenia to horses and the conceptualization of affective disorders to donkeys, one conceptualization of schizoaffective disorder could be whether the horses and the donkeys are in the same field, which means to say whether the schizophrenia and bipolar disorder both are actually happening concurrently in the same person. Now, if that were the case, then we would expect that the chances of both happening in the same individual would be very, very rare, because that would mean that somebody who has a chance of schizophrenia, somebody who has a chance of bipolar affective disorder, and somebody who has to beat the odds of both of them, so that incidence of schizoaffective disorder would have been very, very rare. So, but the reality is it's far too common. So it cannot be that schizoaffective disorders represents schizophrenia and bipolar affective disorder happening in the same individual, right? So next expectation would be, if it is two disorders happening in the same individual, we would expect that the prognosis should be as bad as schizophrenia, isn't it? But the thing is, the prognosis in case of a schizoaffective disorder is not as bad as a schizophrenia. It is slightly better than schizophrenia, and it is slightly worse than an affective disorder. Also, we would expect that since schizophrenia has an earlier age of onset, about 15 to 25 years in males and about 25 to 35 years, that if it is schizophrenia that is happening in this individual along with the bipolar affective disorder, we would have the age of onset which should be identical to schizophrenia, because schizophrenia we understand as a more of a neurodevelopmental disorder. But whereas these things are not expected in case of a schizoaffective disorder. The second conceptualization is, okay, if it is not the concurrent presentation of horses and donkeys in the same field, then is it a zebra that we are looking at, wherein it's a unique thing in itself that is neither schizophrenia nor a bipolar affective disorder. Okay, zebra doesn't resemble a horse, zebra doesn't resemble a donkey. So is it something unique in itself? So if that were to be true, then we would expect, if it is a unique disorder, it should have a unique course and outcome. It should have a unique responsiveness to a therapeutic agent, and it should actually have, it should breed true, like other psychiatric disorders, wherein the first degree relatives should actually have more incidence of the same unique disorder, isn't it? But the reality is there is no clear distinction from typical schizophrenia or affective illness, and the prognosis and the course and outcome is somewhere in between that of schizophrenia and a bipolar affective disorder. And there is a raised incidence of schizophrenia and affective illness in the first degree probands of people who are suffering from schizoaffective disorder, which really tells us it's not a third unrelated disorder. Now, the third thing that we can understand is schizoaffective disorder a genuine interform, wherein we don't call it as either horses and donkeys present in the same field. We do not compare it conceptually like that, but it is a unique disorder which has a mixture of both biotypes and both course and outcomes, wherein we understand it as a mule. So if that is the case, then we would expect the treatment response and the prognosis to be intermediate between the two typical illnesses, which is what happens in schizoaffective disorder. And we should have somewhat raised incidence of schizophrenia also, bipolar disorder also, and schizoaffective disorder in the families of relatives with schizoaffective disorder, and which the course and outcome studies in schizoaffective disorder has proved so. So therefore, the conceptual understanding of schizoaffective disorder holds true as a genuine interform of schizophrenia and mood disorders. But however, it is now understood as a primary psychotic disorder because it is more true to a primary psychotic disorder, right? There are always voices of dissent, because there is the Gershon family study and the Roscommon family study, which found out that the schizoaffective disorder depressed type was much more of a variant of a schizophrenia than that of a schizoaffective disorder, which is one of the predominant reasons why mild depression is never enough to diagnose a schizoaffective disorder. And schizoaffective disorder bipolar type is perhaps an extreme version or a stage 3, stage 4 version of a bipolar affective disorder. So therefore, to overcome some of these problems, when we reviewed literature, we found out that perhaps mood incongruent psychotic symptoms during the recurrent schizoaffective episodes could prove some clues regarding the longitudinal course and outcome of the schizoaffective disorder versus the schizophrenia disorder, right? Wherein mood incongruency is primarily more favoring towards a primary psychotic disorder more than a mood disorder, because in a mood disorder with psychotic symptoms, you expect congruency of mood and the psychotic symptoms, isn't it? Okay. So phenomenologically also, there are certain clues to understand schizoaffective disorder and schizophrenia and bipolar disorder. Delusions at the first presentation are uncommon in a primary bipolar disorder. When I'm talking about the first presentation in the first mood episodes, delusions are uncommon, whereas it can be present, both delusions and hallucinations for that matter can be present in the first presentation of a schizophrenia or a schizoaffective disorder, right? That is one clue towards phenomenologically understanding schizoaffective disorder. So what are the other clues that can give us an understanding of schizoaffective disorder? One is that if you look at the specific types of delusions, like delusions of grandiosity, delusions of persecution, so on and so forth, there are many studies which have initially reported there might be a difference in the type of the delusions, but now when we have synthesized the knowledge, we have found out that there are really no consensus about this particular information. However, when you assess the phenomenology through a detailed history taking, when depression and manic symptoms do occur in schizophrenia, usually the experiences are more incomplete, they are more bizarre, they are more distorted in form and superficial in quality in primary mood disorders as compared to a more complete form, which is actually more deeper, with more systematization and more elaboration in cases of primary psychotic disorders. Now comes the next problem with respect to the first rank symptoms in affective syndromes. Can any PG tell me what is the prevalence of first rank symptoms in say affective syndromes? That is mania with psychotic symptoms and depression with psychotic symptoms. Just take a guess. What is the percentage of presence of first rank symptoms of schizophrenia? Yeah,
20 to 40%.
Yeah, I think most of you have got it right. Like most things in psychiatry, 30% seem to be a magic number. So therefore, 30% of the cases, we see persons having first rank symptoms in mood disorders with psychotic symptoms as well. Now, this poses a challenge for us, especially with respect to ICD-10. It posed a severe challenge for us, wherein we have operationalized the disorder based on the presence of the first rank symptom. So the moment somebody had a first rank symptom, it meant to say that they had schizophrenia, isn't it? So therefore, we could never really kind of talk about people having mood disorders with first rank symptom, because by definition they went into the schizophrenia category. So to overcome this paradox, when they did not classify them as schizophrenia, they found out that 30% is the prevalence of first rank symptoms. And therefore, you have to keep in mind that ICD-11 and DSM-5 are slowly moving away from the primacy of first rank symptoms for schizoaffective disorder as well, right? So when you look at schizoaffective disorder as compared to primary schizophrenias, negative symptoms might be less severe and less persistent. However, they might have more hospitalizations because of the more number, frequency, and severity of the mood disorders with more dramatic presentations. Because mood disorders are associated with more self-harm and suicidal behavior, schizoaffective disorders might have more suicidality associated with it. And also because schizoaffective disorder are not longitudinally as severe as schizophrenia disorders, they may have better insight associated with it as well. So when it comes to the approximate age of onset, about 1/3 of the patients have about 25 to 35 years of age of onset, whereas in 1/3, it is very similar to schizophrenia below the age of around 25, understanding it more in a neurodevelopmental perspective. And in 1/3 of the people, schizoaffective disorder manifests only after the age of 35, which is similar to bipolar affective disorder as well. Right. So we have covered this. So when it comes to DSM-5 schizoaffective disorder, the criteria that I wanted to emphasize is, although DSM-5 does not specify it as more than 50%, it actually talks about schizoaffective disorder as an uninterrupted period of illness, right? Very, very important. The first line it uses is uninterrupted period of illness, wherein in the entire lifetime, in the absence of a major mood episode, wherein you're not talking about the patient having an episode, for about 2 weeks or so, at least, the patient should have either delusions or hallucinations. So this is very, very important for DSM-5 schizoaffective. And for majority of the duration, so when I understood as what majority is, it's in logically speaking, it's more than 50% duration. So if somebody has 10-year duration of illness, so at least for about 5 years or more, the person should meet the criteria for a major mood episode. Mind you, it is not mood symptoms, but it is a major mood episode that they're talking about. And the dysfunction criteria of schizophrenia are not necessary in case of a schizoaffective disorder. Coming to the DSM-5 fine print, it also gives a lot of prominence to pervasiveness of the low mood as compared to anhedonia and anergia. And occupational functioning is not an essential criteria. And if the psychotic symptoms do overtake the mood symptoms over a period of time, so the 10-year duration, somebody had 5 years and 1 month duration of syndromal major mood episodes, it's a schizoaffective disorder. But 2 months later, when they come to you, the same patient can have schizophrenia as their diagnosis. And the lifetime risk of suicide for schizophrenia and schizoaffective disorder, DSM-5 in fine print mentions it as 5%, but which is actually much more in our experience with our cohort of patients. Next comes to another important conceptual understanding of schizoaffective disorder, which is the studies by Marneros et al., who actually said, all this is okay, all this is good. You're talked about the concurrency of the mood, you're talked about the longitudinal perspective, but Marneros really, when he studied the life course perspective of many patients, he said, I don't agree with ICD, I don't agree with DSM. And Marneros gave a different classification wherein he spoke about a particular variety of schizoaffective disorder called as concurrent schizoaffective disorder, wherein somebody has a predominantly schizodepressive course or a schizomanic course or a mixed course, wherein there is both schizomania and schizodepressive mixed episodes happening in each episode, which is far more prevalent in clinical population. But Marneros simplified our life by also talking about the component wherein a sequential variety of schizoaffective disorder exists, wherein some patients manifest with pure psychotic symptoms in one episode, and they manifest as pure depressive episode in another episode, pure manic episode in another episode, so on and so forth. So therefore, it really simplified classification for us. And when he spoke about these types, he also challenged some of the DSM specifiers, which had actually spoken about a bipolar type, wherein DSM had told that if it is a bipolar type, it has characteristics similar to a BPAD. And if it is a unipolar type, it resembles more of a unipolar disorder. And he gave the importance of understanding things in a in a sequential and a life course perspectives away from what DSM and ICD had actually conceptualized. So just to revise, all right, I want to ask a question to the PGs. So if my pointer is visible, if the patient comes to you at this point of time, right? The patient has come to you at this point of time in the OPD, wherein they have had only schizophrenia symptoms, what would the diagnosis be?
Schizophrenia.
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 Very good, very good. But however, the patient developed a mild depressive episode over here. All right. So what would the diagnosis be?
Post-schizophrenic
Episode.
Post-schizophrenic depression in case of an ICD, or in case of a DSM, you would still not diagnose it. Yeah. So then if the patient had the mood episode, which then started fluctuating in nature, and at some point of time over here, if you look at it, 50% was mood episode, 50% was psychotic episode, but here more than 50% became mood episode. What would the diagnosis turn to?
Schizoaffective disorder.
Schizoaffective.
Schizoaffective disorder. Excellent, excellent, very, very good. So I think conceptually, through the past, say, half an hour and 40 minutes, what we have discussed has kind of helped all of us to understand the life course perspective of these disorders. And so that next time that you draw a life chart, if you remember this, it will become very easy for you to understand. So Malhi et al., who was very critical of the DSM and the ICD conceptualization of the schizoaffective disorder, really pointed out to a life course perspective wherein they talked about really looking at least 5 to 10 years duration of time, wherein we would get an understanding of whether we are talking about a primary psychotic disorder or a primary mood disorder. So what they really told is, in the earlier biotype, if you also look at Dr. Machari Keshavan's work on the biotypes of schizophrenia and Malhi et al. Conceptualization of schizoaffective disorder, they really speak about and waiting for about 5 to 10 years before we really lock in on a diagnosis of schizoaffective disorder, right? So some statistics which are important, like bipolar affective disorder, schizoaffective disorder is more frequently present in women, and it occurs 1/3 as commonly as schizophrenia. So the lifetime prevalence is about 0.3%, and 20% of the presentation, or 1/3 of the presentation, is between about 25 to 35 years. When it comes to differential diagnosis, we have spoken how it could be schizophrenia with affective symptoms, it could be mood disorder with psychotic symptoms, it could be post-psychotic depression, or an unspecified schizophrenia spectrum and other psychotic disorder in DSM-5, wherein somebody has just delusions plus a mood episode specifiers, so on and so forth. So over a period of time, over the past 45 minutes, I'm sure all of you would have enough experience now to give the differential diagnosis and justify the differential diagnosis for your long case in the examination. Some important rules of thumb, and I'm coming to the last few slides of my presentation. So please try to conceptually understand these disorders. Whereas a brief psychotic disorder will not have any mood disorder associated with it, it is also not expected to have any negative symptoms associated with it. Whereas in schizophrenia, you expect negative symptoms to be present. In fact, some people argue very vehemently for the fact that negative and cognitive symptoms of schizophrenia are the primary or the first symptoms of schizophrenia that manifest. And socio-occupational dysfunction is an essential criteria for schizophrenia according to DSM-5, whereas it is not an essential criteria for schizoaffective disorder, or in fact any other psychotic spectrum disorder. And for schizophrenia, you need 6 months of combined duration of illness which satisfies the criteria, whereas for a schizoaffective disorder, we should have 2 weeks of independent psychotic symptoms which are away from any syndromal mood symptoms, and 50% of the duration of the over the lifetime has syndromal mood symptoms associated with it. And schizophrenia symptoms, schizophreniform psychosis is something where we do not again expect negative symptoms. So these are some rules of thumb which should help you to differentiate between these disorders. So continuing on, if somebody asks you what are the famous studies that you are aware of in schizoaffective disorder, I would encourage all the residents to go through what is called as the Marneros et al. Study, that is also called as the Cologne study, wherein they looked at the longitudinal course and outcome of schizoaffective disorder by following up patients for more than 25 years. And they had a good cohort of individuals, more than 100 in each category. And they have found out that there really is two types which we spoke about, that the concurrent schizoaffective disorder type and the sequential schizoaffective disorder type. They also found out that 30% of the cases have monomorphic kind of a picture, wherein they have similar kind of mood episodes, similar kind of psychotic manifestation, whereas in 70% of the patients, there was a polymorphous picture wherein the polarity of the episodes were changing or the content of the psychopathology were changing. Very, very important. They actually spoke about how the index episode is not an indicator of subsequent episode, wherein they said that index episode could be mood, index episode could be psychosis, index episode could be mixed, index episode could be schizoaffective itself, but that is not a proven peg in itself, which could actually indicate to us that the patient is going to have a schizoaffective disorder or schizophrenia disorder. So this is very important because we might be tempted to think so. Next, they also spoke about the fact that in patients with polymorphous schizoaffective disorder, the change in the presentation, the psychopathology, the course happened about 7.5 years after the first manifestation, and it reached the 72% of the cases that they defined within the first few years, right? Then coming to the comparison between the monomorphous and the polymorphous, they really said that there is no consistent clinical demographic predictor that could say that this patient is likely to have a polymorphous course or a monomorphous course. And that is something that we have to also keep in mind about the index episode. So they also said that if it is a unipolar schizoaffective disorder, there is likely to be lesser episode, a lesser annual frequency, less number of lifetime cycles, less annual frequency of cycles, and longer cycles because unipolar depression is more common. Whereas as compared to bipolar schizoaffective disorder, wherein we are likely to see more episodes, a higher annual frequency of episodes, more cycles and shorter cycles, and a higher annual frequency of cycles. This is actually very, very commonsensical if we know the course and outcome of both depressive disorders and bipolar affective disorders. So they really spoke about something called as a continuum of affective spectrum, wherein they said that they did not think that these are schizoaffective was a primary psychotic disorder. Marneros et al. Consistently argues that it is in the affective spectrum domain, wherein schizoaffective states is in one end and the unipolarity is in other end. And at the basal things, we get all different varieties of mood and bipolar affective disorders. Coming to the course and outcome of schizoaffective disorder, it is variable. 30% of them have a deteriorating course. 10% have poor diagnostic stability, which we know over a period of time. And the schizoaffective mania has a better prognosis compared to the schizo depression, which is understandable because we just spoke about how the cycles are likely to be shorter, they are likely to present.
Doctor, kindly unmute yourself.
Yeah, I have unmuted myself. Thank you. So schizoaffective mania has a better prognosis, again, which is commonsensical because it presents to the emergency more often, it is treated more aggressively, it has shorter cycles associated with it than schizo depression, which obviously has a 10% risk of suicide. And the Harrow's 10-year outcome study obviously spoke about how bipolar affective disorder has a best outcome as compared to schizoaffective disorder, which has a better outcome as compared to a pure schizophrenia disorder. So as psychiatry junior residents, you must also know that there are certain poor prognostic indicators in schizoaffective disorder, which is a family history of schizophrenia, a poor premorbid functional status, poor premorbid educational status, more psychosocial adversities, absence of any precipitating factors, a predominance of well-systematized psychotic symptoms, an earlier age of onset, and a poor interrupted episodic recovery. If these things are present, you can reasonably kind of predict that these are poor prognostic factors. A rule of thumb, which I want to tell all psychiatry PGs is, if the examiner asks you a question on prognosticate this case, which means to say that you've actually answered your examination well, you've answered all the basic questions well, and therefore you should know about these things to answer even better and finish your examination presentation on a high. Now coming to the last couple of slides on treatment principles, mind you, schizoaffective disorder will not figure out in any treatment guidelines as a separate entity. There are some rules of thumb based on published studies and meta-analysis and systematic reviews, which I've tried to summarize. So general rules of thumb based on the Levinson article in 1999, which I encourage all the residents to go back and read, is that all atypical antipsychotics which are successful in schizophrenia are efficacious in schizoaffective disorder as well. And antipsychotic monotherapy itself might be good enough for both management of the mood and the affective symptoms. So do not right away go in and give antidepressants plus antipsychotics. First, see if the resolution of psychosis with second generation antipsychotics itself might actually decrease the mood symptoms as well. And if depression persists beyond psychosis stabilization, then antidepressants have a specific role. Lithium specifically as an adjunct has open label case series and anecdotal evidence, but there is a condition apply clause that I will speak about later. When it comes to specific RCT level evidence and bigger cohorts of open label evidence, Cohen et al. Demonstrated the superiority of olanzapine over haloperidol in schizoaffective disorder. Now, this is understandable, especially if the cohort included more schizodepressives as well, because haloperidol we know has reasonably no role in the treatment of depression. In case of schizomania, haloperidol and risperidone are both equal in efficacy, but not in tolerability as expected. And in case of schizodepression, you would always prefer, anybody who has a predominantly schizodepression course, you would always prefer a second generation antipsychotic over a first generation antipsychotic. And in the recent years, there has been focus on understanding the course of long-acting injectables in schizoaffective disorder. And they have found out that especially paliperidone and paliperidone injectable formats are superior and effective as compared to the placebo, and sometimes they have found equal superiority as compared to other second generation agents as well. And just like in schizophrenia, clozapine definitely has a role and superiority in refractory schizoaffective disorder. Mind you, at the end of the day, we have called it as a primary psychosis spectrum disorder, isn't it? Last question which I want to ask the postgraduates, can any postgraduates tell me what is the FDA approved treatment for schizoaffective disorder?
Paliperidone.
Good. So paliperidone is the right answer. So some other rules of thumb is that risperidone, olanzapine, aripiprazole are all effective concurrently with mood stabilizers depending upon the course and outcome, whereas long-acting injectables might be better. Now, when I said that, condition supply clause is there, and I will speak about it in my last slide, the important thing to understand is whenever there are new evidences coming in RCTs, you have to understand that the RCTs are going to examine newer drugs more than some of the older drugs, and therefore some of the older drugs really haven't got a chance as much. So if given a chance, maybe they too, like Dinesh Karthik, will make a comeback in schizoaffective disorder, but some of them have not really got a chance. But given the available evidence, with a pinch of salt, you have to now say that paliperidone, risperidone, ziprasidone, and aripiprazole, plus or minus mood stabilizers, depending upon the course and outcome, might be reasonable strategies. If you look at specific RCT level evidence and specific case series level evidence, you will find that some people have recommended carbamazepine to be better than lithium in schizoaffective disorder and flufenazine to be better than lithium in schizoaffective disorder. However, I wouldn't mention this necessarily in the exam because they are not being replicated well, and this is just for your theoretical finding. So in the exam, a golden rule of thumb is that we shouldn't commit only to a pure schizophrenia or a schizoaffective disorder. If you have got reasonable evidence for both, depending upon what we discussed, always give a differential and give a never ever actually give a comorbid schizophrenia and a bipolar diagnosis. Remember, Kraepelinian dichotomy, and most of your examiners are likely to be very well versed with the conceptual understanding of these dichotomy and very well versed with the standard historical textbooks of psychiatry. So if you say your patient has both schizophrenia and bipolar affective disorder, that's not going to go well in the exam. So do not say that, and do not exclusively give a management plan for a schizophrenia or for a mood disorder. Please keep in mind that you have to take the life course perspective, the recent episode perspective, and give course and out, depending on the course and outcome, you have to give a management plan taking into consideration both the psychosis and the mood symptoms. Okay, so as somebody rightly pointed out, paliperidone is something that has been FDA approved for schizophrenia. And if you want a last statistic which can help you to understand what is the prevalence of affective symptoms in case of lifetime prevalence of psychiatric affective symptoms and the lifetime prevalence of psychosis symptoms, probably schizophrenia, schizoaffective disorder, and schizophrenia plus mood disorders are likely to have 35% lifetime prevalence of active psychotic symptoms, whereas bipolar disorder will have 40% or more prevalence of active mood symptoms, and schizophrenia treated successfully will have less than 20% likelihood of active mood symptoms. With it, I end my presentation. I want to tell all of you that schizoaffective disorder is a nosological nuisance, but it is definitely a clinical reality. And I hope that this webinar will kind of better equip all of us to help diagnose this important disorder and treat our patients who at the end of the day will receive better care, hopefully, as we gain more and more knowledge. So with this, I also want to thank Dr. Paneer Selvam sir, Sneha Mind Care, Dr. Nurul, and Anil Kakunje sir, Dr. Anil Kakunje sir for this opportunity. And I would like to thank, most importantly, all the participants. About 200 of you have joined on a Sunday afternoon to listen to this talk. Thank you. It is your participation that makes teachers like us to kind of read more, be on our toes, and hopefully come up with better and better talks in the future. Over to the moderator.
Sir, thanks a lot for the excellent presentation, sir. Really, I became a JR. Even I blurted out an answer as like I'm feeling like a JR. Anyway, so thanks a lot for the great presentation. So a couple of questions in the chat box. So the usual question, when we come across a question in exams, schizoaffective disorder is episodic or continuous? The unending question. So one of the participants has asked this question, sir, how to handle this question and how to understand this.
Yeah, so I think if the examiner asks you this question, it is probably a good idea to talk about with perspective of ICD and with the perspective of DSM. And you can say that conceptually, ICD kind of talks about it being an episodic illness with concurrent presentation of both the mood and the psychosis episodes, and DSM speaks about it being a longitudinal illness wherein there is a concurrence of these symptoms, but there is an independent period wherein psychosis symptoms are also there. So over a period of a lifetime, I think each individuals will come up with their own course trajectories. So it's very difficult to say that they're 100% of the schizoaffective disorder patients are going to have a purely episodic course, because quite really we see that only in about 30 to 50% of our cohort, whereas in 20 to 30% of the patients we see more of an continuous course, and in 20% of the cases we see some atypical patterns of course as well.
Okay, so another important question, sir. Sir, I'm presenting a case. So I'm showing the live shot of the examiner. So a couple of mood episodes, independent episodes, and one pure psychotic episode. So when I am telling the diagnosis, so where should I fall? Because the sequential or concurrent type of Marneros classification may not help us in the exam when we discuss with the examiners. So when we have this kind of course or episodes in our hand while presenting the case, so how do we handle that?
Yeah,
we fight for the diagnosis kind of.
Yeah, this is a very, very important question by Dr. Nurul. And this is precisely what forced the ICD-11 people to come up and specifically write in the classification, in the ICD-11 version, wherein they say, before the onset of the psychosis, episode, the patient can really have a course or outcome which resembles more of depression or even a manic or a mood disorder. So I would take the refuge of ICD-11 and say that longitudinally I'm going to follow up this patient for a schizoaffective disorder because they have manifested and they satisfy the criteria for schizophrenia at this point of time, which will also satisfy some of the experienced and seasoned examiners who would actually still want to stick with some of the fueled hierarchy. So always kind of, give that a special emphasis. So I would go in that way. And I would, however, be reasonable enough to tell to my examiners that, sir, I would like to clarify for the frequency and duration of these episodes, because you got 40 minutes in the exam.
Yes.
So it is impossible in that 40 minutes to by a fine line to kind of delineate this. Some of us who are following up patients for about 5-6 years now have still difficulties in putting them under these categories. So in 40 minutes you can always commit to one and be flexible enough to tell that I would actually want to follow up the patient, clarify things more. Never be adamant in the exam that okay, I have attended this class, I will know everything, and I have ICD-11, DSM-5, and so I will stick to this. So never fight with the examiner on that. Always be flexible. That's the best approach.
So thank you, sir. Sir, another question in the chat box, sir. So, how we differentiate between RDD with psychotic symptoms and schizoaffective depressive type? So the prospect or retrospect or confusion.
Can you please tell that again? I didn't get the question.
Sir, how we differentiate between RDD with psychotic symptoms and schizoaffective depressive type?
Yeah, that's a very good question. So in case of an RDD with psychotic symptoms, you wouldn't get psychotic symptoms in the remission and the recovery phases of the RDD at all. You would get the psychotic overlap when the severity of the mood congruent psychotic symptoms, and these psychotic symptoms go away when the person's mood disorder is treated adequately. Whereas in compared to a schizoaffective disorder, wherein the psychotic symptoms may persist despite the patient not meeting criteria for a syndromal mood disorder, wherein the patient might have a well-systematized chronic delusions or hallucinations which are mood incongruent in nature, and they satisfy other criteria for schizophrenia disorder without the presence of a mood disorder.
Thank you, sir. Thank you. Is there any evidence that quetiapine is better than other antipsychotics in treatment of schizodepressive disorder?
Yeah, so I would actually kind of bring the condition supply clause over here. So Seroquel, which is the FDA-approved molecule of quetiapine, has been studied extensively for bipolar depression, and we all know 300 to 600 mg studies on quetiapine, and especially the 300 mg, which was equivalent to the 600 mg in bipolar depression. The same has not been, unfortunately, replicated in schizoaffective disorders. So which meant to say, although on paper, quetiapine, which is like an ideal mood stabilizer / antipsychotic, I wouldn't call quetiapine a mood stabilizer. Some of the old, conceptually, it is not a mood stabilizer, but an antimanic, antidepressive, antipsychotic like quetiapine, although on paper it sounds ideal, has real world evidence in case of schizoaffective disorder. I think the role of clozapine is something that 2-3 times people actually asked in the chat box. Clozapine definitely has a role in schizoaffective disorder. Mind you, clozapine is being revisited for treatment-resistant bipolar disorder as well nowadays. So if you look at the Kabzanski staging of bipolar affective disorder, and if you're getting stage 4 Kabzanski bipolar affective disorder who are resistant to mood stabilizers and antipsychotics, we have enough evidence now to say clozapine is effective in bipolar affective disorder treatment refractory itself. So definitely clozapine has evidence in treatment resistant / refractory schizoaffective disorder. But in the exam, please do not mention clozapine if you are not sure, if you have not established treatment resistance / treatment refractory status.
Thank you, sir. Thank you, sir. So many applause for the great presentation from senior psychiatrist Dr. Anandavalli Madam, Anil Kakunji sir, and Dr. Malavika and Vaijayanti Madam.
Dr. Anil Kakunji, you are fine. Your comments?
I think it was an excellent presentation. So, Suhas doing excellent job.
Your audio is not clear.
Moderators, Dr. The efforts of Dr. Ashwath and Noor has been very good, and full thumbs up to Dr. Paneerselvam for a wonderful organization and bringing this program evolve.
Thank you, sir. Thank you, sir.
Looking forward for future programs.
Thank you, sir. We all need your support of senior psychiatrists like you, sir. Thank you, sir.
Yeah, I think there's an audio problem with Dr. Anil Kukunji, I think.
Yes, sir. Sir, let me read out the winners list who answered the question from Dr. Suhas sir. Dr. Srini Prakash Siddhan, Dr. Shamini, Dr. Ankit, Dr. Kavita Parthipan. 4 people will be awarded the prize before the next presentation. Congratulations for the winners.
Dr. Noor, you note down the name and also the number so that we can get the address of from which medicals they belong to. Then we will hand over the prize and the certificate to them. Thank you. Thank you, Dr. Sudas, for your wonderful and informative presentations.
Thank you, sir.
More than 200 participants there till the end of your presentation. That it shows that your quality of presentation.
Thank you, sir.
That's very kind of you. Yeah. And also I thank Dr. Anil Kukunji, my junior from Mangalore, for sparing his valuable time to chair this session. And I also thank my junior psychiatrist, Dr. Nurul Hasan and Dr. Ashwath Babu, for a wonderful moderation and help to continue to conduct this program in a very smooth and successful manner. And also I thank all the participants for their active listening and the discussions. And if the PGs want PGs a participant, if you want the link of the presentation, we have a recording of the presentation is there with the East West Pharma. If anybody want, they can ask the representative, the East West Pharma representative will provide them. And also our next scheme will be on 23rd November. The speaker will be Dr. Narasimha from All India Institute of Medical Sciences for Diogar. And the topic will be the substance abuse. We'll finalize the topic and let you know in the subsequent week. And thank you for the sponsor. And I asked the East West Pharma for the vote of thanks. With that, we can finish the session.
Yes, very interesting and useful insights on a complex mental disorder. Thank you very much, Dr. Panneerselvan, for having brought once again to the Evolve platform a topic of great relevance to postgraduate students as well as practicing psychiatrists. Thank you very much, Dr. Anil Kukunji, for having consented to be the chairperson for the session. And the session was very well moderated by Dr. Nurul Hasan and Ashwath Babu. And Dr. Suhas Satish's presentation was demystified the psychoaffective disorder. I'm sure there are a lot of takeaways for the postgraduate students. It was exam-oriented even, and reading between the lines and reading all the lines. I'm sure they will be immensely benefited by this presentation. And Dr. Panneerselvan, I really want to specially thank you because I now can envisage the Evolve platform going on a broader canvas and becoming a pan-India academic initiative. Great work by all of you together and great quality and depth of discussion. Thank you very much, everyone.
Thank you. Thank you to everybody. Thank you to the organizers.
One suggestion to Suhas.
Yes, yes.
You can get it published, Suhas, as a review article. You have done a lot of work. So I feel you should put it in print.
Thank you, sir. Thank you for that suggestion, sir. Very kind of you.
Suhas sir, I'm not sure whether this content was added in the tips reading material. Tips.
No, this is a
kind of summarizing note that we have not heard anywhere. I have heard for the first time when I was preparing for my MD exam. We had taken a series of lectures for our class. So after that, many people got a chance to listen to this. So if you give it as a good summary on this disorder in tips writing, sure. We have great help for the future generations.
Sure, definitely. Thank you, Nurul. Thank you so much.
This is a training initiative for postgraduate psychiatric residents, sir. So it's being written with the being supervised by Suhas sir, and many of the authors are there. We will share the recent PDF on tips in the group, sir.
Sure. We'll do that. Thank you so much for the opportunity. And
thank you.
Thank you, Dr. Thank you, sir. Thank you.
Thank you so much, sir.
Thank you.